Recording. All right. So ICD-10-CM chapters 1 through 5. So we're not doing all of ICD-10 tonight, just the first quarter of it. So question number 1. What ICD-10-CM code is reported for pneumonia due to adenovirus?
Um,
So
you would come
the what is our main term that we're going to look up in the alphabetic index?
adenovirus.
Pneumonia.
Yep, it's the
Pneumonia.
pneumonia. Yep, that's the condition, is the pneumonia. Okay, so underneath pneumonia, we'll go down to adenoviral, or you can go to, I thought they had a due to option, but they don't. So we will just go to, or yeah, there's an in/due to, and then adenovirus underneath that. So does everybody see one of the two? Pneumonia and then adenoviral, or pneumonia and then in or due to and then adenovirus. So what code do we have for,
J12.0.
yep, so J12.0. Okay. Any questions on that one? Number 2, what is the ICD-10-CM code for a patient with postoperative anemia due to acute blood loss during surgery who needs a blood transfusion? So what is yep, our main term is going to be the anemia. Underneath anemia, we will go to postoperative. And then due to acute blood loss. And then what code will we choose from there?
D62.
Okay. Does everybody agree on that one? D62? Okay. Number 3, this is going to be just a guideline-based question. You might have a question like this on your CPC exam where they kind of test you to know whether or not you know your guidelines. When it is documented that the patient is both using tobacco as well as has a dependence on tobacco, how should we report that in your ICD-10-CM?
It's reported as dependent.
Yep. Yep. So if we're going to go by that hierarchy, right? So dependence
Yes.
is going to be like basically our top tier. And then underneath that, you will have abuse, and then use is our lowest. So if we have use as well as dependence, we are only going to report our dependence on the tobacco. And that goes for any drug. Okay. That's not just tobacco. That's for any psychoactive substance use, abuse, and dependence. Okay. Any questions on that one? Perfect. Number 4, a patient is admitted to the hospital or sorry, they were admitted to the hospital with streptococcal group B severe sepsis, and that has caused pneumonia and acute renal failure. So let's look at this one from a process of elimination standpoint. Okay. So we have A and D that have A41.9. And then we have B and C that have A40.1. So let's go look at one of the two and determine which one of those two we should use, because either way, we're going to rule out two options. So let's go look at A41.9. That's the one I'm going to go to first. A41.9 is sepsis with an unspecified organism. And then A40.1 is for sepsis due to Streptococcus group. So do you think we should use A40.1 or A41.9?
A40.1.
Yep. Yep. So we're going to rule out A and D because A41.9 is not our sepsis code that we should use. J15.3 is in both, so I'm just going to ignore that code for now. So then we need to go to R65.20, determine if we need that code or if we should only code the J15.3 with it. So R65.20 is going to be for our severe sepsis without septic shock. So even though we have our sepsis code, the A40.1, that's the sepsis due to the streptococcal group B, should we code the R65.20 for the severe sepsis?
I'm going to say no because it's already in our first code.
So if we look at the description for the R or the A40.1, does that just describe sepsis due to streptococcal group B, or does it include severe sepsis?
Oh, okay, yeah, okay.
Yeah. So we do need it because we have to indicate that it is severe sepsis and not just regular sepsis. And then Dawn says that it should be R65.21. Where is our septic shock coming in from?
I'm sorry, that was a mistake.
You are fine. You are fine. I just wanted to make sure you were on the right path. So we do need the R65.20 because it does indicate that they have severe sepsis. If you get confused, there is a guideline in chapter 1 as far as how to code severe sepsis, and it does indicate that if severe sepsis is present, then we should not only code the sepsis, but we should also code the severe sepsis code. Okay. So again, C has our correct codes, but it needs additional codes as well. So we always want to make sure that we're coding the full picture and not just a portion. Okay. Any questions on that one? Okay. Number 5, 23-year-old patient presents to the emergency department with a cut on his leg. He is a confirmed AIDS patient as documented within the record. So what ICD-10-CM codes should be used? So here's where I want to know from a process of elimination standpoint or a testing standpoint, okay? If we have confirmed AIDS, what ICD-10 code should we be using?
B20.
Yep. B20. Even if they say that it's confirmed AIDS and they are asymptomatic, should we use B20 or should we use the Z21 code if they state that they are asymptomatic?
Asymptomatic.
So, Kristen, you say yes, even if they're asymptomatic. Why should we always code B20 even if they're asymptomatic? You're not wrong. I just want to hear your thought process.
I'm trying to remember exactly because I
Nope,
saw the guideline. I just read this guideline yesterday. So, because it is a disease state that there's unfortunately not yet a cure.
Mhm.
That's my thinking on that. But I just, I wish I could be more specific. I apologize. But I
No,
do
no, you're
remember
fine. I know
them,
what you're trying to say. Yeah, I know exactly what you're trying to say. If
they're,
they
yeah,
have asymptomatic HIV, then it would be the Z21, right?
right.
Because they only have the virus present. But once it has conformed into AIDS, once they have AIDS, they can never go back to being truly asymptomatic, if
Okay.
that makes sense.
Yeah.
So once you put a B20 on a chart, you should never code anything other than a B20 moving forward.
Okay. Is there a way to denote that there is that a patient's asymptomatic? I mean, it feels like it's like it's like pertinent information to know that, even if they have the B20.
Well,
Um,
I mean, and it all depends on the documentation. Your
right.
documentation might say patient is AIDS, but not currently experiencing symptoms,
Okay.
right? But we know that once they have AIDS, then it should always be B20. And
Okay.
that's in our, like, you can even go to your alphabetic index
Right.
and look up AIDS and it will put in their B20, even if it's asymptomatic.
Okay. Thank you.
You're welcome. Absolutely. Now, the other thing from a testing perspective, if you look at it, your fracture code is all the same, right? So from a testing standpoint, we wouldn't even have to look up our fracture code because we know that that code is the same. So we just need to know if they have AIDS, which one we should use, and then that'll tell us our answer automatically. Okay? Any other questions on number 5? Okay. Number 6, we have HIV if they are asymptomatic is Z21, I think. Hang on. Now that I'm saying it out loud, I don't know if my brain is.
Yeah,
Yes,
it shows.
Z21.
Yeah, it's on G7. It shows that.
Yes. I don't know why my brain just like second guessed my. I even second guessed myself after so long. It's fine. It's human nature. So yes, Z21 if they are asymptomatic. Okay. Number 6, a 50-year-old patient has a mass removed from the chest, and the surgeon sends it to pathology. Pathology report indicates that the mass is a benign tumor. So for this one, where do you want to go look in the alphabetic index?
Tumor.
Okay. If we know that it's a benign tumor and we know that behavior, we can actually just go ahead and jump directly to the table of neoplasms. So we can go neoplasm and then chest, because that's our anatomic location. And then our behavior is benign.
D36.7.
Okay. Does everybody see D36.7? Okay. Any questions on that one?
I have a quick question. Sorry about that.
Okay. No, you're fine.
Sorry, this is my first time doing a meeting like this, so I'm just
No,
getting used to
you're totally fine. You're totally fine.
Do you, like you do with tabular, do you with neoplasm tables, like if you didn't have the code right in front of you, would you then go to the tabular list after you check the neoplasm table to make
You
sure that?
should. Yeah.
Okay.
Yeah. You should always look at your tabular, yes, to verify.
Okay. Okay.
Yep. Good question. Okay. Number 7. So we have a 32-year-old patient with hyperthyroidism and they have an ultrasound to determine why her neck is enlarged. The results of the ultrasound reveal a uninodular goiter. So what code should we use? So let's do this one from looking at the alphabetic index. What main term should we go look at?
Goiter.
Okay, let's go look at goiter. Where would you go underneath goiter?
Unidular.
Okay. Before you get down to uninodular, if you look directly underneath goiter, underneath your with, you have a with hyperthyroidism option, right? Where does it tell you to go for that?
The hyperthyroidism.
Yep. Yep. So we first need to go to hyperthyroidism, and then we'll go to with a goiter. So we'll do hyperthyroidism with a goiter, and then it is nodular, and then uninodular. So I've got, so Tansy, how did you get E05.20?
Yeah, I'm just now realizing this one says multinodular.
Well, the multinodular is in the parentheses. Do you remember what the terms inside the parentheses are called?
The no.
They're called non-essential modifiers.
Oh,
So
no.
if we think about what non-essential is, right, it's not necessary for that word to be there, right? So if they do state that it's multinodular, great. If not, it's okay. But then we need to go down underneath uninodular because it does indicate that it's uninodular and there's not multiple. Does that make sense?
Yes, this makes sense. And then this code has the goiter in it. So the other ones don't specify that.
Which other ones?
Like EO 5.10.
Oh, were you looking at, or are you just going directly to your tabular?
Yeah.
Okay. Yeah. So the E0510, let's look at the actual code description. So E0510 is thyrotoxicosis with a toxic single thyroid nodule. And then if you look at the inclusion note under E05.1, it says thyrotoxicosis with a toxic uninodular goiter. So
Oh,
that
gotcha.
thyroid nodule is going to be the same as a like a uninodular goiter.
Okay, yeah. I think I always get hung up on making sure the code has word for word, but I forget that there's parent codes and parent codes and codes that are underneath that.
Well, be careful because you don't want to mix up your terminology from ICD-10 to CPT because
Oh,
in ICD-10 they're not true parent codes, right? Your parent
yeah.
codes are going to be when you pull a certain portion down in front of an indented code with your CPT. Whereas with ICD-10, we have categories and subcategories.
Yeah, okay.
So with your E0510, we want to go up underneath the subcategory E05.1 and look at our inclusions and then if there's exclusion notes and things along those lines.
Okay.
Okay. So does that make sense why we're going to use the E0510 instead
Yeah,
of the 20?
yeah, that makes sense. Yeah.
Okay.
Sorry about that.
No, no, you're totally fine. That's the whole point of us doing this is I want to make sure everybody's on the right page.
Okay. Thank you.
Okay. You're welcome. Um,
Before
is it Jenny Stapleton? Is that who Stapleton is? Is that Jenny? Yes. So are you good with why we're using the E0510 and not the E04.1? Or do you need a little bit of an explanation on that? Okay, good. Good. So the reason why, because I think I see somebody else. E04.1 is if there's not hyperthyroidism with a goiter. The E04.1 is just going to indicate that a goiter is present. Because I saw somebody else say the E04.1 as well. So I just want to make sure everybody's on the right page. We're using E0510 because that includes your hyperthyroidism, which is the thyrotoxicosis, versus the E04.1, which is just indicating that a goiter is present. Okay. Any questions on that? Is everybody good on that explanation?
I jumped in kind of late and I'm so sorry, but before
No.
we move on too far, I was trying to get my placing. I know that the guidelines for AIDS is once you've been diagnosed with it, you do get coded B20, but I was wondering the difference between B20 and Z21 as far as like HIV goes, because that always confuses me.
Yes. So Z21 is going to be just when the virus is present and they are asymptomatic. Whereas B20, and I use the phrase full-blown AIDS. I use that very loosely because it's probably not the best description of it. But they are now not only just present with it in their body, but it's actually starting to show symptoms and become a syndrome versus just the virus being present with no symptoms. Does that
Okay,
make
so
sense?
if a patient presents but has no symptoms, like if they were previously diagnosed already but they're not showing symptoms, I still code Z21.
No, if they have AIDS, once you assign B20, you will always have B20 that point moving forward. Because
Okay.
even if they're not showing symptoms, then the virus isn't just present, it's already kind of quote unquote wreaking havoc on the body, right? So once it has started to show symptoms, then you will always have B20 instead of Z21. So
So
once
if
you have AIDS, you'll never go back to not having AIDS.
so if this is like their initial consult and they get a test for it and it's positive that day and the doctor says it, that's B20.
No. If they are positive and not showing symptoms, that is Z21.
Okay, got it. So only with a previous history on their medical record.
Correct. Yes.
Got it. Thank you.
You're welcome. Okay. Any other questions? Okay. Let's do number 8. So a lab screening shows congenital iodine deficiency hypothyroidism for an infant that is identified with an intellectual disability. So what ICD-10-CM code or codes are we going to report? So let's look up the congenital iodine deficiency hypothyroidism first. So we'll go to hypothyroidism. Underneath hypothyroidism, we're going to go to iodine deficiency and then congenital. And where does that send us?
Syndrome.
Yep. So we have to go to main term syndrome, iodine deficiency, congenital.
E00.9,
Okay. So we know E00.9 is our code. So we're going to rule out option B. Are we also going to code our intellectual disability?
yes.
Okay. So we are going to rule out letter C because we know we need that as well. So now the real test comes because F79 is in both, right? Which one should we
Yeah.
sequence first? Should we sequence the iodine deficiency or should we sequence the intellectual disability first?
Wouldn't it be the iodine deficiency because that's acute, isn't it?
Well, it's what they're coming in for. Yeah. Yeah. So that screening, they're having that done for the iodine deficiency. And it just so happens, and again, I'm using that phrase loosely, it just so happens that they have that intellectual disability as well. So the intellectual disability is not what caused the screening. They're there for the screening, which is going to be is going to make that our first listed diagnosis. Does that make sense?
It does. And then also, isn't it true that because they have that disability, you will always code it, correct? With that,
You
whatever that
should.
child's
Yeah.
coming in for, right?
Yep.
Okay.
You should.
That's what I
Yeah.
thought.
hmm
So if in some alternate universe iodine deficiency hypothyroidism was sequela of the disability, would it be flipped? I mean, would we then?
It would depend on the reason for the encounter. So
Okay.
again, if they're coming in for treatment for the hypothyroidism,
Okay.
and then it was a sequela of the intellectual disability, then
Right.
because the treatment is being directed at the hypothyroidism,
Okay.
then it would still be listed first. Again, in those circumstances, it's going to be dependent on the reason for the encounter.
Okay.
Yep.
Thanks.
So clear as mud.
Sorry, just backtracking a little bit. So whenever a patient comes in with a disability, we code the disability first for the reason for the encounter?
No. In this instance, they are there for the screening.
Okay.
So the reason for the encounter is going to be for your hypothyroidism.
Okay. Thank you.
You're welcome. Okay. Let's do number 9.
I'm
No,
sorry.
go ahead.
Can you go again? You went to thyroidism, but it said go to syndrome. And then syndrome, you went to the iodine?
Yes. Syndrome, we go to iodine deficiency congenital.
I'm just having a hard time finding that. Sorry.
No, you're fine. Do you have the AAPC 2024 version of the ICD-10 book? It is on page 334.
I am on there and I am blind, I guess.
It's
All right,
in
I'll
the
find
third column. No, you're fine. Third column, about like 5 lines down.
I got it. Thank you.
Okay, you're welcome. I know sometimes your eyes play tricks on you. Okay. Any other questions?
Yeah,
Number 9. Yep. Okay. Number 9. A 32-year-old male was seen in the ambulatory surgery center for the removal of 2 lipomas. One was located on his back and the other was located on the right forearm. Both involved your subcutaneous tissue. Okay, so let's go to lipoma.
Would it be valid to go to excision first?
Well, we're not coding procedures.
Oh, right. Okay, I got it.
Nope, you're good. I know that's what everybody always goes into that mindset of we have to code our procedures.
Got it. That's a good reminder because I've been so focused on CPC and HICS for the last few weeks. So yeah, okay.
Yep. So always just look and see what code it's asking for before you jump to procedures, because sometimes your questions will only ask for ICD-10, even though they're telling us what procedures were being done. They're only asking for your ICD-10 codes. Yep.
Okay, that's good to know.
Yep.
Good to know.
Okay, so underneath lipoma, which ones do you want to do first? So we'll do lipoma site classification. Do you want to do the arm or the back first?
Usually what's listed first, correct?
It's whichever
So
way.
For the arm, I
Okay.
have D17.9. Wait, I'm sorry.
No, you're fine.
D17.2.
Yep, D17.2, and then we have to expand it. Okay. So we know D17.2 is going to have to be used. So we can rule out letter A and we can rule out letter D because we know we have to have a point two something. And then for your trunk, for your back, that would be on your trunk. So that would be your D17.1. So let's go look at the D17.2, figure out if we need a 0.21 or a 0.23.
It's 0.21.
Okay. I'm moving slow tonight, so it's taking me a minute to get there. Yes, so it should be 0.21 because it's the right arm, not the right leg. So we need the D17.21. Okay, any questions on that one?
So it goes kind of like from your head to your toes with the codes, like head, shoulders, knees, and toes.
I was just about to sing that
So
song.
typically, your numerical order, typically, I don't want to say all the time because every time I say that something is for sure, then they're always going to throw something in and mess it up. But typically they will go heads down to your toes. So they'll do head, neck, shoulders, arms, legs, or shoulders, arms, hands, and then chest, trunk, hips, legs, toes, feet, all that. Yeah.
Cool.
Yep. And then typically, again, there's going to be some instances where I'm going to put my foot in my mouth and it's not always going to be that way. But typically, your ones are going to be your right, twos are going to be your left. But like in this instance for the D17.2, you have right arm, right leg, left leg. So there's a 3 and a 4. But typically, if you only have just arms in one subcategory, legs in another subcategory, 1 would be your right, 2 would be your left. Okay. So why would we do the arm first? Really, in a real world scenario, Jenny, then as long as they're coming in for the same thing, then your sequencing doesn't matter first and second, as long as the 2 reasons for the initial encounter, the 2 reasons for the encounter are listed first. And then if there were any other conditions, then they would just have to be sequenced third, fourth, and fifth instead of second, third, and fourth. Okay. Let's do number 10. A male patient is seen by his primary care provider for rectal bleeding and persistent intestinal cramps. After a colonoscopy with biopsy, the results come back, and the provider documents that the patient has a malignant neoplasm in his sigmoid colon. So where are we going to go first?
Table of neoplasms.
Okay. So we'll go table of neoplasms. Let's look at this actually from a testing perspective really quickly, too. So if we have our definitive diagnosis is the malignant neoplasm of the colon, are we going to report our signs and symptoms?
No.
Correct. So we can automatically rule out C and D. right? Because we don't need the K62 or the R10. Okay. So let's just get a little bit of practice with the table of neoplasms. So table of neoplasms, and then what's our anatomic location?
Rectal.
For the neoplasm, it's your sigmoid colon. The bleeding is in the rectum, but the anatomic location is the colon.
Intestine.
Yep. Yep. So you'll go neoplasm, intestine, and then large colon, and then they tell us it's this sigmoid. So we'll go all the way down to sigmoid. So make sure you're going all the way into your indentation as much as you can. And then it's a primary malignancy because they're not telling us that it metastasized or it spread from somewhere else. So we can assume that it's primary. So what code are we going to use for the primary malignancy? So Tansy, make sure that you go all the way down to large colon and then sigmoid. Because your C18.9, you just stopped at large. So you have to make
Yeah,
sure you go
sorry.
all the way down. No, you're fine. I just
I
wanted to make
actually
sure you
meant to put
followed.
C18.7. I don't know
Okay.
I don't know what's
No,
going on with me tonight. I'm
that's
sorry, guys.
fine. You are fine. So C18.7. See, and I'm looking at the C18.9 and selecting the wrong one. So C18.7 is going to be our malignant primary neoplasm of the sigmoid colon. Okay?
Can
Any?
you
Yep.
can you explain so I kind of got lost. So sigmoid, flexure, lower, upper. How did we distinguish which sigmoid to use?
Um, so underneath intestine, you want to go to large and then colon, not sigmoid flexure or the sigmoid or the splenic flexure. So you want to go intestine, large, colon, sigmoid, which I guess really it gives you the same answer either way. It gives you the C18.7 either way.
Oh, I see. Okay. Okay.
Yep.
I was going lower. I went into
Yeah.
the
And I didn't even see that one down there, but yes, that one is an option as well because that flexure again is your non-essential modifier, right?
Oh,
So,
it's good. I know I'll end up on the same code. Okay, cool.
yep.
Thank you.
Yep. So you're on the right one either way. Yes, Jenny's right. There is an anatomic picture in the codes that will help. Is it in the next to the C18 or is it in the digestive system that you're thinking of, Jenny? I know there's a really good one in the digestive system. Okay, and by C18. Do you have the AAPC version of the book or do you have a different publisher of ICD-10? You do not have the AAPC. Okay. Which one do you have by chance? I'm just curious. You have Optum. Okay. I feel like you're typing the answers as I'm asking the question before I even ask it. No, you're fine. You're fine. Some people have AAPC and some people have Optum. I know some people use Decision Health. So each one of the publishers is going to have different like anatomic drawings and things. So if you have the AAPC version of the book, in the beginning of your digestive system, chapter 11, then there are some really good anatomic illustrations in there. So pages 745 through 747, there's some really good illustrations in there to kind of help you keep track of which part of the colon is what.
Yeah, I was just looking at page 745, and on the left-hand side with the body, you can see it there. It says sigmoid colon. So
Yep.
maybe highlight that as a reminder.
Yeah. Yep.
And also, can we maybe add, like, write that page number in um, where we were looking for it in the tabular or in the
Yeah,
neoplasm?
absolutely.
Okay,
Absolutely. You
that
can
way
write
it'll
page
help me.
numbers anywhere
Yeah,
you need to. Yeah,
perfect.
for
Thank
sure.
you.
You're welcome. Oh, good, Jenny. I'm glad they gave you your voucher back. I know you were working on getting that resolved. I'm glad that you were able to get that done. All right. Any questions? Anything you guys want to chat about tonight? We've got a couple minutes left. Um, Anybody have anything that they want to chat about ICD-10 wise? I know that we have a lot of new names on here too. So if anybody has any questions about what to expect moving forward.
I actually have a question. It's
Yeah,
Debbie.
yeah.
Hi, Tiffany. So, okay, so quick question, and it's regarding medical terminology.
Okay.
Um, how much of that is involved in the actual exam for the CPC?
Directly related to midterm, I think there are 5 or 6 questions. Um, but med term is going to kind of be spread out like everywhere.
Okay.
So, like for instance, we need to know, let me see if there's one on here that um no, there's not one on this one. So
Like
like
for
for instance,
AFib?
yeah. Yeah, so
Okay.
that could be one where they might just say it's AFib. We may need to know, and I'm just going to kind of fast forward a little bit to like some CPT. We need to know that like if you are removing your thyroid gland, right? We
Hmm.
might have to look up thyroidectomy, right?
Okay.
So if they just say removal of the thyroid gland and there's not an option in the index to say, removal and then thyroid, then you have to know that it's a thyroidectomy. Or your code description is going to say thyroidectomy type thing.
Sorry, go ahead.
No, you're fine. Go ahead.
I was going to say, do they use a lot of abbreviations in the exam?
Abbreviations, probably not.
Okay.
Acronyms, you might see a few, but it's not going to be super heavy. Like
Okay.
acronyms are going to be very common acronyms that they're going to use,
Yeah,
like
like NEC.
cabbage, B, like a TAH BSO for the abdominal hysterectomy with your bilateral salpingo oophorectomy. You might see some things that are like that, but there's not going to be any acronyms on there that's not like standard verbiage.
Very good. Okay, thank you.
You're welcome. Absolutely. Tansy,
And
what's your question, hun? Oh, no, go ahead, Debbie. Did you have another one real
I
quick?
all I wanted to say was thank you. This is actually very, very helpful. So I appreciate
Good.
it.
You are very welcome. I'm glad that you were able to join this week.
Yeah,
Tansy,
thanks
what you got?
again.
Hey, sorry. Yeah, I was gonna say to Debbie, they also NEC or NOS, I think
Yeah.
something like that. I got those in both of my practice exams. I don't know if that's a common one or not. But yeah, so yeah, I'm just not comfortable with ICD-10-CM. I don't know why. I'm very comfortable with CPT, but with ICD-10-CM, I'm just not. Um, as far as the guidelines, what guidelines do you recommend to kind of watch, like to study more than others, just so I can, because I'm taking my exam in 2 weeks, so I'm kind of trying to jam everything in. So yeah, what do you recommend for guidelines?
That's such a loaded question.
Yeah, it is. It's a loaded.
Because it all is just going to depend on the version of the exam you get and what questions they pull for the exam. So, what I like to tell people, especially if it's ICD-10 that you're struggling with guideline wise, ICD-10 is easier to learn than just general CPT guidelines because we know that CPT guidelines are strung all throughout the book, right? Whereas your ICD-10 guidelines, even if it's just, hey, I only know I have 5 minutes. I'm sitting in the carpool line. I have 5 minutes. I'm just going to read through a couple paragraphs, right? Try to read through your ICD-10 guidelines as many times as you can between now and 2 weeks when you test. Because if you can do that, you're not going to necessarily remember everything that's in your guidelines. You're not going to remember the words and every single little nuance in it, but you're going to remember, oh, yeah, I remember them saying something about hypertension and CKD. Let me go look at that. I remember that they said something about primary versus secondary neoplasm. Let me go look and see what they said about that. So again, it's not going to be a matter of how much can I memorize between now and 2 weeks. It's going to be how much can I say. I just need to become familiar with what the types of information that and the types of guidelines and sequencing guidances that are in there, so that I know when to refer back to my guidelines. Does that make sense?
Yeah, that makes sense.
Okay.
I think I spent so much time on my CPT that I
Yeah.
neglected my ICD-10, and I'm definitely seeing that in this study tonight. So
It's very,
yeah.
yes, it is very easy to do because especially you went through an AAPC course, right?
Yeah.
Yeah. So with the AAPC course, they do focus mostly on CPT, and that's just because that's the bulk of the exam. But again, just kind of go back through and just read those, even if you skim them, right? You don't have to read them word for word. And like I said, memorize them. Just get familiar with the types of guidelines that are in there. So, like I said, you know when to refer back to them. That way, you're not looking for things that you don't know if they're in there or not.
Okay, thank you, everyone.
You're
Thank you,
welcome.
Tiffany. This is all very helpful. Thank you, guys.
Absolutely. You're very welcome.
Tansy,
Any other questions?
I was
Oh,
going to
go
say,
ahead.
Tansy, I probably need to learn from you for CPT because I haven't even started that yet, and I'm getting through my ICD book. So I think we're backwards, you and I.
Yeah, pretty
Maybe
much.
I'll help you, and you can help me.
Okay, I'll send you a message.
All right. Any other questions or anything that you guys want to chat about? Well, I'm glad you were able to join, Bila. I know that there were a lot of new names on tonight's session, which it makes me happy because that just shows that there's different groups that are out there that, are just now learning about it. But if you all have any questions whatsoever, I put the link for the chat, the Discord group. That's a really good support chat group in there. And then that link to the Google Doc that's got all of the recordings and things moving forward. So if you guys think of anything that you need in the next week, don't hesitate to reach out, whether it be Facebook, Discord group, whatever it is. And I will chat with everybody next week. Y'all have a good night.
Thank you so much. Good night.